also the regional clinical lead for ENT, and within that, the GIRF program is part of the remit. And so I'm hoping that everybody here is today understanding this is a Hereford and Worcestershire ICS gateway review. And what I was going to do is, if we can just do some introductions simply on the chat function, if you'd be so kind as just to introduce yourselves on the chat function, your role, and what your position is within the ICS, or either at Wye Valley or at Worcestershire, that would be really helpful. And Nikki is going to be taking the minutes today, and I noticed we are recording. So I would also like, if possible, and this is not because of any particular seniority or anything, but if we can have the clinical and operational leaders just very briefly introduce themselves, who are the service leads for ENT and the operational leads for ENT at both Hereford and Worcester. That would be very helpful. And also whether there's any members of the divisional directors or executives, that would be fantastic as well. So if they could just drop in and verbally introduce themselves, then we'll carry on with the rest of the meeting. That would be great. So please fire away if you're any of those, and we'll pick up everybody else in the chat. So that is okay. Julie, you got your hand up?
Yeah, shall I make a start? So my name's Julie Briggs. I'm the operational lead at Worcestershire Acute Hospital. Mr. Lewis hasn't yet joined us. He's having some problems joining, so I'm just going to take myself off camera and see what the problem is. So I will be back with Mr. Lewis, hopefully.
Okay, that's fantastic. Thanks, Julie. Is there anybody else who's from Worcestershire, and then we'll move on? Anne Williams, go for it.
Hi, I'm Anne-Marie Williams. I'm Trust Cancer Services Manager here at Worcestershire Acute, but as of yesterday, I am going to be operational lead for all things ENT, amongst others, for the directorates. I'm taking on that role until the end of March.
Great.
Nice to meet you.
Fantastic. Thank you very much. And is it Catherine Simcox?
Yes. Hello. I'm Kathleen Simcox. On Monday, I will become the Divisional Director of Operations for the Surgical Division in Worcester Acute.
Okay. Thank you very much. And we've got there's another hand, but I can't see who that is.
It's Rebecca Pritchard, I think.
Thank you. Thank you very much.
Yes, it's me. It's Becky Pritchard. I'm the Director of Support Manager for ENT.
And you're at Worcester as well?
I'm at Worcester Acute, yeah.
Worcester. Is there anybody from Wye Valley on the call? Oh.
Yeah, I'm Vanessa Hick. I'm just standing in at the moment, picking up some things from Chris Beaumont, who's our GIRF lead here. So I'm sort of sitting in the background a bit, but we are expecting our ENT consultant and Vanessa Lewis, our lead.
Thank you very much. And Mahmood Akhtar?
Yes, I'm a consultant urologist, and I'm also for the Wye Valley Trust as an Associate Chief Medical Officer for the surgery. And I'm sure I've seen Simon Clavers, one of my colleagues, who's a consultant ENT, on the call here.
Simon, are you there?
Yeah, hi.
Hi, Simon.
I'm Simon Prouse. I'm a consultant ENT surgeon. I'm clinical lead for ENT. I should point out this is my after a 3-month period of sickness, so I won't.
Sounds like you've got a very noisy Dyson in the background.
It's not me actually; it's someone else's Dyson.
Okay, right. Sorry, Simon, we missed some of that. You're for those who don't know, you're the clinical lead down at Hereford and Worcester. Sorry, down at Y Valley.
Down at Y Valley. It should be pointed out, this is my first morning back after a 3-month period of sick leave. So I don't aim to be contributing particularly to the meetings. Obviously, I've not had time to be fully appraised or briefed.
Okay.
But I'll contribute.
Okay. Thank you very much, Simon, for coming to the meeting. Okay. Is Stephen Lewis in the meeting yet? You hear Stephen?
I certainly am, Mr. Trotter. How's life with you?
Very good. Very nice to see you. The IT issues are always the issue. So Stephen, if you could just introduce yourself for those who might not know you.
Yep, my name's Steve Lewis. I'm an ENT surgeon and I am clinical lead for the service for Worcestershire, which ends up sharing quite a lot with the service in Herefordshire, and hence you've got us both.
Smashing, fantastic. Okay, so what we wanted to do is we'll just have a real 2 minutes of what the plan is today, and then I'm going to hand over to Stephen and perhaps Simon if he's to just talk about their services at Hereford and Worcester, and then we have got the data packs that we're going to go through and use as an aid memoir, really, just to start the discussions rather than to go into huge amounts of depth. So if people remember, of those who haven't been involved in GIRF before, GIRF is a program, a national program, to look at seeing if we can standardize outcomes, standardise ways we do things to reduce variation across the organisation, individual organisations, individual ICSs and regions. It's there to help with the quality of access and equity of access. And I suppose these GIRF reviews are to help us understand your services and why there may be variations in individual services across regions, which may be absolutely explainable and understandable and particularly nuanced for your individual areas. So we're looking at some individual benchmarkings, and we're keen to try and identify great areas or good areas of practice and how you actually do those within your individual setups, and understanding how you think we, as the GIRF, both regional and national teams, can help move forward with any plans that you may have and support your plans to improve the aspirations of GIRF. So I would absolutely like to emphasize this is not about us performance managing or making any suggestions of how you should be performance managing. This is not the way it is. I would like to just remind on housekeeping that if people can go on mute if they're not speaking, please use the virtual hands if you want to make a comment, and please don't feel free to make a comment. Don't bottle it up. The more people involved in this conversation, the more we're going to get out of it. And the aim is that the GIRF team will come back to you with a report and recommendations on the things that you've described. So hopefully that is a brief reminder of why we're here. And I can see that Frank has got his hand up already. So I've obviously said something wrong, because Frank is our national ENT GIRF lead.
I just want to introduce myself and let everybody know that I'm attending really as an observer, because I'm learning this process as much as everybody else is at the moment. So my name's Frank Stafford. I'm the national lead for ENT for GIRF. I'm actually a head and neck surgeon in Sunderland in the northeast of England, although I have worked in various different parts of the country during my time. And just to say thanks for letting me attend.
Thanks, Frank. So Steve, would it be appropriate to come to you first to give us a quick few minutes about how ENT at Worcestershire is configured and your relationship with the Y Valley group?
Yeah, that's absolutely fine. Thanks, Matt. So I have got a population of about 600,000 patients. I've got 5 consultants working in a rota that should have 6. There's an advert out last week if you know anyone who's interested in being an ear surgeon locally. I've got a couple of training registrars and a small army of middle grades. We work very closely with our audiology department, who number 50 or thereabouts. Mel, there's lots of you, aren't there? The geography is interesting because we have the Worcester Royal Hospital, which is our main hot site. We have 2 other sites, one being the Alexandra Hospital in Redditch in the north of the county, which is a pretty substantial centre as well. And we have the Kidderminster Treatment Centre, which is a day case unit in effect for our purposes. So geographically, we live at the Worcester Royal, and the reason we live at the Worcester Royal is that it's closest to Hereford, where Simon and his colleagues live. That's important because we share with them and they support us in our on-call rota, and we tend to take their ENT head and neck surgery because Simon, as I'm sure, or Safe will explain, they don't have a dedicated head and neck ward in the Wye Valley Trust in Hereford. So we borrow Mr. Warner, who comes across every Tuesday and brings patients with him. So geography is an interesting part of our life. The Kidderminster Day Case Unit works very well from a Worcester point of view. We only operate, so we run outpatients on 4 sites because we use the small hospital in Evesham as well, but we only operate on 2 sites, being the Worcester Royal and the Day Case Unit in Kidderminster. And being ENT, the vast majority of the throughput goes through Kidderminster. And I'm doing this from memory because I'm using 2 computers and I can't open the presentation with the numbers on. But from memory, in terms of throughput, in our last complete year back in 2019, we saw 24,500 outpatient contacts, and with a conversion rate of about 10%, which is about average for the UK. That's 2,500 operations, of which 700 were inpatient on the Worcester Royal site, and the rest were day cases in Kidderminster. So we run a shared system at the weekend where the Hereford consultants, numbering 4, are added to the Worcester consultants, numbering 6. So we do 1 in 10 weekends. And at the weekends, we also share the take for Worcestershire and Herefordshire. And anyone who needs to be admitted comes to the Worcester Royal site. So that's kind of an outline of who we are and where we are. What sort of detail do you need?
I think that's really helpful, actually, Steve. I mean, it will be the stars for 10, and what I was proposing is just to get Simon just to briefly talk about the Wye Valley setup, and then if it's okay, then we can start going through some of the data and moving on from there, if that's okay. But gives a really good feeling for how you got your setup within Worcestershire. So thanks very much. Simon, do you want to have a few words?
I'm very happy to. I noticed my colleague, Mr. Al-Zahid, has just popped in, but he may have access to a bit more data than I do. But I can sort of flash out what Steve said as of when I went off in March. So we're a much smaller hospital. We cover a population of about 200 to 250,000 people, which is geographically very dispersed. So we cover Herefordshire itself, which is very rural, and into mid Wales out here halfway to Aberystwyth. So some of our patients will have an hour and a half, even at extreme 2-hour journey to get to our hospital. We're a 4 consultant unit, myself, Savita Kale, Giles Warner, and Saif Al-Zahid. We're supported by a middle grade doctor, a training post, which is filled by an MTI trainee presently, and an FY2. We are really largely elective unit. We operate 9 a.m. till 5 p.m. Monday through Friday. So we do outpatient clinics, and in terms of operating, that would be all general ENT, including diagnostic head and neck. We do not offer resective head and neck surgery. As Steve's already alluded, my colleague Giles has sessions at Worcester where he takes on our head and neck cancer work. So that's all performed at Worcester Royal with the inpatient ward there. We do the full gambit of otology and rhinology, with the exception of skull-based work, obviously. We are primarily a day surgery unit. We do sometimes admit patients for 24, 48 hours for drains and the like, but we don't have a dedicated ENT ward, so patients are generally cared for on a surgical day surgery unit or the surgical ward very rarely. We also have a paediatric ward, and we do manage a small number of paediatric inpatients. In terms of emergencies, we're the first port of call for any emergencies 9 to 5. After 5 p.m, the only on-call ENT we have is the consultant, who's available if there's a life and death emergency in A&E. Otherwise, all lesser emergencies get routed through to Worcester. As Steve's already intimated, at the weekend, we shut completely, and all on-call is joint with Worcester. We're a single site hospital. We do have a number of cottage hospitals, but none of those really have an ENT service. We run an outreach clinic to a hospital in the middle of Wales, Landrindod, Wales, where we hold 3 outpatient clinics a week. And we do have the facility for day surgery operating, although that's probably underutilized. That's about it. I haven't got access to any particular numbers. I suspect that our inpatient throughput is a lot less than Worcester. My last reckoning was somewhere around 10,000 patients a year. That's all I can really say. I noticed that my colleague, who is more up to date, probably has joined the call, so I'll probably bow out, and that's probably all I'll contribute.
Thank you, Simon. Thanks very much indeed. So just a couple of questions that have arisen then. So back when we're talking about Wye Valley and Hereford, do you have set days that you operate, or would you be having patients in over the weekend who have come in for that day or two that you describe for drains and etc., or are all those patients operated on earlier in the week?
Yeah, if there was a patient who required ongoing inpatient care on a Friday, they'd be transferred to Worcester. Okay. We don't generally, we have set days of operating, and on a Friday, we have a Friday morning session, but we wouldn't sort of put anything on that was likely to stay overnight, for example.
Okay, and the middle grades presumably cross cover. Well, they don't travel, or do they travel?
Yeah, there's a shared there's a shared weekend rota as well. So we contribute. I think it's a 7-man rota. Steve will correct me if I'm wrong. And 2 of those slots are covered by Hereford, Wye Valley.
Right. Okay. So no, that's really helpful. That's fantastic. I think that sort of gives us, for those of us who don't work down in Hereford and Worcestershire, that gives us a great sort of understanding of how the units are set up. Frank, you've got your hand up.
Yes, please. Can I just ask, have you had any residual hangover from the COVID crisis in relation to your facilities? Have you lost operating lists or beds, or has it affected you in any other way that you haven't quite recovered from yet?
Steve, do you want to start?
Yeah, from a Worcester point of view, yes. If you imagine, well, take the number I said earlier, 24,000 outpatient appointments a year, and we more or less shut completely, with the exception of 2-week wait and very urgent, for a total of probably 4 months, third of a year. So our first headache is 8,000 people we haven't met on the waiting list. And because the space we're allocated in the hospital is relatively small, and because we were using flexible nasendoscopes, which potentially aerosol generating, we put the nasendoscopes in separate rooms in order that those rooms could be cleaned appropriately, which of course instantly reduces the number of working rooms you have. As well as that, we lost our footprint in the trust to teams who needed it more. So we used to have a footprint at the Princess of Wales Hospital in Bromsgrove, which we have lost completely. And we have given up lots of space in the Kidderminster Treatment Centre area where we used to have outpatient clinics. And we still have some, but nowhere near the number of rooms we used to have. So I think we are running at the moment at about 70% of our, no, maybe 75% of our previous outpatient capacity. And well, you can do the math yourself. If you knock a quarter off 24,500, that's another 6,000 a year we're behind with. We did have a significant restriction in terms of theatre. And I think we are now up to, well, 95% or so of what we used to have in terms of access to theatre, but it's not the same theatre. So in Kidderminster, it's adult day cases. It works really well, but and one day a week we have, by special arrangement, some capacity for children. Although there are quite a lot of restrictions on exactly who you can send to Kidderminster. And we're a little bit nervous about anyone who's sort of ASA, 2, 3 and above. Our paediatric base for the county was compressed into the Worcester site. We used to have paediatrics at the Alex as well. We don't anymore. It's all been centralised in Worcester because of paediatric staffing and safety and perfectly good quality measures. But that also means that we're sharing access to the paediatric ward with all of the paediatric emergencies for the county. And that means that our access to beds on the Worcester site for paediatrics is limited. And thinking about the 3 sites, there are very few people who, so most people go to Kidderminster and that's fine for day case surgery. The head and neck ward, if you're having a laryngectomy, you have that in Worcester and there's no argument about those things. There really is only a very small group of patients who would be sick enough they couldn't go to Kidderminster, but not so sick they didn't have to come to the head and neck ward. So we used to operate at the Alex as well in Redditch, but actually we don't. It's an economy of scale thing. It's just not worth opening that and having a third set of kit and a third set of skilled staff. So since the COVID pandemic, we have been pushed off the Worcester Royal site. And we feel a little disadvantaged because patients have to be well to get an operation in Kidderminster, and it's a bit restricted for children. And of course, 20–25% of what we do, same as everyone else, is kids, which is a bit tough.
That's really helpful, Steve. Is there at the present time, Worcestershire has got an application in for some funds from the Elective Recovery Fund. I don't know whether anybody from the organisation is able to confirm or comment whether you've been successful in that.
Mrs. Briggs, do you know the answer to that question?
I'm not sure whether he has, but have been successful. My apologies. I'll see if I can find out during this meeting.
Okay. So there's a hand up from Emily there.
Yeah, just to confirm, we're at outline business case stage. I'm hoping to submit the business case in July. Similarly, Wye Valley Trust, they submitted their outline business case. I think it was end of last week. So both of those 2 elective hub bids are progressing in line with the timelines.
Okay, so based on that, Emily, what is the provision of ENT services within that business case for, because I understand it's for an elective centre at Redditch?
Yeah, I'm afraid I don't know the detail in terms of each of the individual specialties. That will come through in the outline business case, which isn't due from the trust until July time. I think Stephen Goodyear is hopefully going to come in with confirming.
Come through, Stephen. Stephen?
Sorry, it's almost like it's my first time on Teams. My apologies. Yes, as you say, it's a business case for an elective centre at the Alexandra, which is essentially re-providing the theatre capacity, which is out of date markedly. But also within that business case is some additional capacity to refurb and keep open the existing theatre stock in order to catch up effectively from the pandemic. So it's part of the elective recovery programme of the Trust. In terms of how that's likely to impact ENT head and neck services, it will push additional elective activity away from the Worcester site, and hopefully we'll start to see that from the end of September of this year as part of a concurrent reconfiguration of services programme, and that should free up some additional capacity within the Worcester Royal site for the head and neck elements of that. We're also looking at some investment in equipment for the Kidderminster Treatment Centre site, which will allow some of the cases we currently only do in Worcester to be facilitated at Kidderminster.
So do you know, Stephen, if there's any plans for within your hub site at Redditch, whether paediatric surgery will be done there as well or not?
That hasn't been explicitly discussed, I'll be honest. Yeah. I would suspect that the answer is probably no, and that's based upon the fact that paediatric surgery requiring an inpatient stay would have to be on the Worcester Royal site, which is where our paediatric services are based. As Steve Lewis mentioned earlier, that was due to paediatric workforce and staffing, which required compression and centralisation of their services to their base at the Riverbank unit in Worcester. So my suspicion is, whilst it may be possible to facilitate some day case access over there, I don't think it will make any inroads into those requiring inpatient stay, which would be Worcester.
Yeah. And do you have a dedicated paediatric day case unit down in Worcester to facilitate day case paediatric service, or are they competing with the inpatient beds for a day surgical bed?
No. So at the Kidderminster Treatment Centre site on Fridays, weeks 1, 3 and 5 of every month, we have all of that unit, so 4 theatres and 2 treatment rooms dedicated to paediatrics.
That's a
Kidderminster Treatment Centre.
Okay. And so you don't bring any, so the only paediatric operating that you do down at Worcester is those that will require an overnight stay?
Correct.
Okay, fine. So the vast majority is going up to Kidderminster?
Yes.
Okay. Thank you. Steve?
Yeah, just to add to that piece, in our division of surgery, clearly the project is the hot-cold site split. And I find myself making the same comment that I did Thursday last week in a different meeting, that there are some, because we are a small consultant group, and Mr. Goodyear feels my pain because he's a vascular surgeon and he has a similar small consultant group who cover Herefordshire as well. So geographically, our base really has to be at the Worcester Royal. It doesn't work if you move it to the top end of the county or anywhere else. So we find ourselves stuck, in inverted commas, on the hot site. And that's a problem because, of course, you come in on a Monday morning and the hospital's full because it's a hot site because it's got an A&E department. So a hot-cold site split has 2 weaknesses. One is that anyone left, like vascular or maxillofacial surgery or ENT, with their elective surgery on the hot site, really has to be ring-fenced or it doesn't work. And the political one is, if you try and run a cold site with an A&E department, that's not a cold site either, but I'm keeping out of that one because that doesn't bother me because I don't go to the Alex very much other than outpatients. So it's clearly the project, but it's got 2 little wrinkles in it which we need to sort out.
So Steve, do you run your elective workload whilst being on call?
Yes, we do not cancel elective planned work whilst we are on call. But the deal is, because we're travelling around the county, there's always a consultant on the Worcester Royal site, and that's the hot site. And although we run an on-call between sort of Monday to Thursday and then Friday goes with the weekend, in truth, for example, I'm always on site in Worcester on a Wednesday, and I deal with everything between 8 in the morning and 5 p.m. And then the on-call guy picks it up after 5.
Yep. Absolutely. So is there any need, requirement, necessity to facilitate moving stuff out of Worcester electively for you that you could look at from an on-call provision point of view, as in having to look at one person on the site, maybe a hot week on call? Would that work, or is that something you've looked at?
We have looked at it, and our colleagues in maxillofacial surgery have a very similar setup to us, and they're finding that their on-calls are busy enough that they are now having to cancel their planned work in order to be on call. We haven't found that's the case yet, and that is partly because we are supported by 2 training registrars, an associate specialist, and 2 experienced staff grade doctors. So if you have to get up and out of the clinic and spend 2 hours doing an operation, actually the whole system doesn't fall over. So we just suck it up.
Okay, that's great. Thanks, Steve. Thank you very much. So should we move on to the data pack, unless anybody else has got any more comments to make? And then Kieran, would you mind popping the data pack up, please? So this is the data pack, which hopefully you've all been circulated and been in a position to see. It's a number of slides, but generally speaking, the way we do this is just to go through some of the data and to then be able to use it as almost like a starter for 10 for a discussion. So if we go on to the next slide, please, Kieran. So you're doing very well from an ENT point of view. You're one of the providers which got no 104-week waits, which is good news. Next slide, please, Kieran. And then your 78 to 104 weeks are primarily those in outpatients, please. Next slide. And there's your inpatient surgical wait of 14 patients who are over 78 weeks. You may be aware that there are, at Worcester, there's 827 patients who are waiting longer than 52 weeks at the moment, as of end of April. And Wye Valley has got 12 patients who are waiting longer than 52 weeks to be seen or treated. I was wondering if we can just use that as a sort of a starter for if you can put some meat on the bones about how you manage things like advice and guidance, if you use advice and guidance, or if you use any other referral management tools in triaging patients before they get into your clinics, or globally within the hospital, any particular system that is used?
So in Herefordshire, do you want us? Yeah, in Herefordshire, we have a advice and guidance system whereby a couple of the consultants go through the list and reply to those. We also have an electronic referral system, e-referral system, which we take turns to go through. And if anything needs to be referred onwards, where it's audiology, we don't necessarily have to see them face to face. So we would refer onwards electronically. So we've got a good electronic system that's linked to all the GP primary care, and we can triage it that way.
So that's really interesting. So can you put a little bit more meat on the bones with that? So how does that work? A patient gets referred down to Hereford. Do you then in the ENT department see every single referral that is coming in? Does it cross a medical person's virtual desk to triage that?
Yes, very much so. It's an electronic system that it gets refreshed by the minute, by the hour. So as a GP puts in an e-referral, it comes up to our systems where we just click on the referral, and then we have a couple of options. We read the referral, then we can either accept, redirect, or reject. And if we reject it, we would get in touch with the GPs via letter or telephone, or refer onwards to a speech and language therapist, for example, or audiology if it doesn't need to see us. And then they would electronically also be in the same system. It's called the Maxims system. They would then, it would go on their desktop, and we see this on almost a daily basis. obviously we get a nudge from the secretaries if the e-referrals start building up, but that's essentially quite a manageable system.
And how many referrals would you be getting into that system a day from an ENT point of view?
I would say on average probably 10 to 20, yeah, thereabouts.
And are you given time in your job plan to do that?
So it's not a specific time as such, but we have SPA sessions, and I suppose it's not a timetabled session, but we take it amongst ourselves to sort it out between us in our admin time, or even in between clinics. Sometimes if there are 2-week waiters that are waiting, the secretaries will often give us an email to tell us.
So I don't know if there is anybody operationally who can put some more meat on the bones from a Wye Valley point of view. Do you have Choose and Book open at Wye Valley? Is that how you're accepting referrals?
I don't know about that actually. Vanessa might be able to help in here. Vanessa, do you know if we have Choose and Book, please?
Really sorry, I'm not we do have Choose and Book, but I don't know whether it's open at the moment. I'm not the best person. I don't get involved with the referrals and the electronic aspects of things, so I can't help, but I can find out if that's helpful.
That would be really helpful, actually, Vanessa, if you can confirm that, because that's quite an interesting model that you're using down at Hereford and Worcestershire. Hereford, to manage the referrals, because a number of organisations that the consultant colleagues or the medical staff don't actually see the referrals at all, and then being in a position to triage or redirect is a very effective way of doing things. But it would be interesting to understand if those patients are booking via a Choose and Book system or a different electronic referral system. So it'd be great if you could give those details. That'd be helpful. Simon.
Yeah, Matt. We were Choose and Book before COVID. It got suspended during COVID, and as of when I was last working, which was March, we weren't back on Choose and Book.
Right. Okay.
I had to look at that, whether we were going to go back on.
Okay, that's helpful to know at this stage. Steve, what happens up at your place from a point of view? Do you know if Choose and Book is open? Are you?
We're in the same. We were running it pre-COVID. I'm not sure if it's currently still running. And we have a similar referral system. So when it's my Monday to Thursday on call, there will be about 50 referrals a day come through the electronic referral system. They used to come, in a brown envelope, and you sort of open them and scan the note and write routine, urgent, 2-week wait, or sort of write a note back. We do that electronically now. It does take a little longer, but it's all trackable. It probably takes a minute per referral, maybe 45 seconds. And we are able to upgrade or downgrade. I think there is a little weakness in our electronic referral system, in that if I am told that if I reject the referral with a note back to the GP, they do get it, but they don't get that in a very timely fashion. So I'm nervous of that piece of the system. So there'll be probably 50 a day in true referrals, and there'll be maybe 10 a day in the advice and guidance system, which comes through to the email address of the consultant on call. And that really is just I have a tendency to do that on my own computer, because I can dictate into it. So you can write a better response to the GP. And I have a few standard responses, like, the thyroid guidance that sort of goes, a U2 nodule, you don't have to follow up. And I just drag and drop the link in and say, it's on page 16 if you're interested, with some pictures. So that system works quite well. The 2-week wait service, we used to, pre-COVID, in order to be able to hit the 2-week wait of 95% target, seeing patients within 2-week wait, within 2 weeks, we used to just blindly book them all in. And we don't do that anymore. We've employed a clinical nurse specialist who filters all of the 2-week waits and runs it through the, the validated risk score calculator that gives you a reasonable idea of what percentage chance that these patients have of having a malignancy. and some of them are downgraded, although when they're downgraded, they normally get downgraded to within sort of 4 or 6 weeks. That system makes me slightly nervous because, of course, if you see 100 people and they have a 3% risk of a malignancy, well, 3 of them will have a malignancy. So that isn't a perfect system, but it helps us manage in a way that we didn't previously. And it does filter out quite a lot of the people with simple globus and quite a lot of those people who have a feeling of a lump in their neck without actually being able to feel a lump in their neck, which is a different disease. So yeah, we have electronic systems sort of parallel to the guys in Hereford. I don't have a system which allows me to redirect to, for example, gastroenterology. It's an into ENT or not. Although I can send it, I can send referrals which are more appropriate for audiology to direct to audiology full stop or to audiology first. And we're also running a program with one of our audiologists who will, if I send her a note to the audiology before ENT clinic, what happens is she'll see the patients, she'll take a short history, and what I get is a one-sided A4 report that has history, photos of eardrums, pure tone audiometry, tympanometry, and this is what I've done. Do you want to do something different? Note. And that's a really good service, which we should expand.
That sounds excellent. That sounds really good. How have you, going back to your 2-week waits, are you using the standard 2-week wait pro forma, the national pro forma, or have you modified that to any extent that then you can put those details into the algorithm and the software?
The 2-week wait pro forma, I don't think is modified, or at least I don't think it's changed for 5 years.
Okay.
And we don't link it to the pro forma. The patients come in on the 2-week wait, and our clinical nurse specialist calls them all back on the telephone and runs through their history with them and fills in the pro forma with them in order to sort of risk stratify them.
Okay, so she will have a telephone consultation with them.
Yes.
Subsequently deciding whether they are suitable based on the risk stratification to go into the 2-week wait clinic.
Yes.
Do you have any details about any audits being in a position to support that? Because that sounds on the face of it, a really good idea.
Well, it wasn't a good idea. It was that we were buried in work and we were worried about being able to hit the target. It was necessity. And when I catch up with Mr. Ashford, I shall ask him to audit it.
Yeah, fine. Okay. So, okay, that's fine. Great. Brilliant. Okay, so if we can just move on from there. So I think, Steve, you alluded to your waiting times for outpatients that were increasing simply because of the challenges that you'd had with the state. Are you back seeing patients in every room, or are you still moving patients to different rooms to be scoped?
It depends on where we are, but mostly we are still scoping them in a different room. We are up to 75% of our original throughput, and
right.
Part of that is actually lack of rooms as well as scoping in a different room, which doesn't slow you down as much as you might think.
No. Has there been any view as to whether the sort of ionizing air purifiers would be worthwhile to be being used in your clinics to allow you to scope and take the history in the same room as we always used to?
I know we've looked at it, and certainly in our maxillofacial surgery department, because they do more aerosol generating stuff, that's something that they went through in some detail, and they have a couple of areas which were upgraded. We did not do that in ENT. And actually, I'm not sure what everyone else around the country is doing, or indeed you can tell me what you're up to. I'm rather hoping that any time soon we'll be just going back to as we were, where we're not quite as afraid as we are, or as we have been.
I can say from our point of view in Hereford, we're back to usual from that point of view. So we're scoping patients as we go.
Yeah.
In the same room.
Likewise. Yeah, that's what we're doing as well. Okay, so do you at Hereford and Worcestershire hospitals, Steve and Safe, do you use patient-initiated follow-ups? Have you started using those? Do you have experience of those? What's your thoughts regarding those?
No, I have no experience of that. What does it actually mean? So
well,
say for example,
we do.
Go on, Steve.
We've got 2 new boxes on the outcome form. One that says patient-initiated follow-up, and there's a sort of there is one where you give the patient the ability to call back at any time up to the next 3, 6, 9, 12 months. And there's one which basically has a fail-safe where they'll be sent for, and one where there is no fail-safe and they won't be sent for. My experience of that is that if you give people access, they use it.
I think my colleagues have their hands up to fill in.
So,
yeah, I use patient-initiated follow-up for my vertigo patients. So, a lot of patients with long-term membranous vertigo, Meniere's, they're pretty stable and then they fall off their perch. So rather than book them in, they have open access via my secretary. And actually, before I went off on sick leave, Vanessa and our business manager, myself, were looking at on a divisional level, rolling that out as a system, similar as they've got in Worcester, with linked into electronic patient records.
Thanks, Simon. Thanks. Vanessa?
Sorry, just on the back of that, we do have a plan to formalise the PIFU arrangement. The delay in that at the moment is related to our Maxim's electronic system, so we're just waiting for a fix in there to allow us to take it more formally.
And is Maxim, Vanessa, your hospital clinical system as well as admin system?
It's going that way, yes.
Right. Okay. So your hospital clinical system is Maxim, or the administration system is Maxim? And
it's like the old PAS with extras, so it's working towards being the clinical system that we will be using. Brilliant.
Okay, thank you. Thanks very much. Okay, has anybody else got any comments regarding outpatients before we move on to the model health metrics? No? Okay, so can we go on to Kieran, if you can go on to the model health metrics, the first page. So these are just a very brief reminder for those who have seen it, or those who haven't seen it, an introduction. These are simple metrics that have been brought out and are used across peers and across the regions and nationally. And there's certain metrics that have been identified as perhaps good to be able to compare your peers to see whether that can be a push to change any activity if the levels are low, or obviously celebrate and share if your levels are high. So why don't we start with a celebration? Your day case rate for ENT across your system is very good. It's 82.4%, which is, as you can see, in a very good place. You're not quite in the top decile, but let's be honest with you, they're probably dedicated non-emergency hospitals which get up to that level. And on the basis that both of the organisations, that both Hereford and Worcestershire, are acute hospitals, that's a really good position to be. I think we've dealt with the barriers to day case that you've discussed, and particularly Steve, you've mentioned it regarding Kidderminster, Redditch, and Worcester, and I think there seems to be some plans and some thought has gone into managing that. And certainly, Simon, you've also articulated how you manage your surgical ENT cohort of patients, and primarily that's on a day case basis, which is good. So you've also talked about how you're configuring those services. So I don't think we need to speak in a great deal more detail. Only, I suppose, to open and see whether anybody has got any burning plan idea as to whether you can increase those figures anymore. They're pretty impressive. If not, we'll go on, Steve.
Yes, one of the things that slows us down in terms of specifically kids and tonsillectomy is obstructive sleep apnea.
Yeah,
we're still running with our anaesthetists the cautious, 5 years ago rules. So anyone under the weight of 16 kilos currently can't go to Kidderminster. They have to stay with an overnight stay at the Worcester Royal. I'm presenting some data at the audit meeting next month on the 7th to our anaesthetists to demonstrate that actually going down to 12 kilos is now the more updated guidance. And we'd like their support with us being able to shift some more people out, because in truth, although we do worry about OSA in kids, none of us can remember a case of a child who actually significantly ran into difficulty whilst being observed at the Worcester Royal. The slight hole in that plan is I know the conversation which that's going to trigger, which is that of our 60 anaesthetists, there are probably 6 or 7 who are really comfortable with small kids on the peripheral site. So the conversation after that will be, so one, can we take these kids, small kids, to Kidderminster? And they'll say, yes, Steve, that's fine. And then I'll say, well, of course, that does mean we'll have to have the fastest 6 anaesthetists. And that'll be a different conversation. Yeah.
Absolutely, absolutely. Well, I was going to come on to that actually. So maybe we'll part that for the conversation around tonsillectomy if we can, Steve, and come back to that. Safe.
Yeah, very much so. I was going to parallel Steve's comments that we can certainly improve on our pediatric OSA day case rates, I think, with introducing some local guidelines. But as there's already a section on that, so I'll leave that for later. Thank you.
Great. And Nikki?
Thank you. I was just going to ask what sort of numbers they were, if you were able to change the weight limit. Steve, what do you think the sort of numbers? Are they small numbers? It's what sort of impact will it have, I guess?
I can't answer that one without looking it up, sorry.
Sorry, it wasn't meant to be a killer question.
Okay, Kieran, if we can just knock to the next slide. So these are the day case rates from the individual providers. It's interesting to see that Y Valley perhaps is a little bit lower than Worcestershire. And I think it's important when we look at day cases, the perhaps disconnect by what we think of as day cases as a clinician with what the organisations think or the model health data is collecting. So if, say, for example, I bring a patient into hospital and I put on the waiting list card that I expect them to have a night in hospital, if they then do go home as a day case, that's not regarded as a day case because your intention to treat as the clinician was as a overnight stay. So therefore the bed is theoretically booked, etc., etc. So I was wondering from the Y Valley point of view, whether you have a intention to treat as day case model, or what you might think is bringing your figures down to 50%. Simon.
Oh, yeah, I said I wouldn't contribute, but these are things I've thought about a lot in the past. And based on my experience, that 50% seems very low. My thoughts are, there's 2 things. One, when we operate on children, on our system, we have to put them as an inpatient because they all get done on the kids ward, pre and post-op. There's no day surgery kids unit. So I wonder if that is then coding them as an inpatient stay. Maybe, I don't know. That's something I'd look at. The second is that we have 7 theatre lists a week. One of them is always on an evening. And consequently, the majority of those patients stay overnight, and that's run by our rhinologist. So I think disproportionately, a lot of our rhinology seem to stay overnight, but it's because they're getting operated on at 6, 7 o'clock in the evening on a Monday. And I can't do anything about that. When I looked at tonsil day surgery rate a few years ago, we had a core group of probably accounting for about 15% of our workload, 20% who just couldn't go home because they were more than, we have a cut off about 35 minutes from a acute hospital. And there was that good percentage, 15-20% of people who I could never do as a day surgery unless we relax that 35-minute rule. And I couldn't find anywhere else in the country that was relaxing that. So I felt pretty anxious about that. As Safe's already said, we have been looking at trying to relax the OSA criteria.
But Simon, this is why these GIRF reviews, the data doesn't necessarily tell the picture. And I think you've just painted the picture as to why in your organisation there are certain things that will challenge you in providing the normal ENT surgical cohort of patients day case surgery, such as operating into the evening, such as geography with patients travelling long distances. So that's a really it's a very valuable piece of information you've just given us there. Steve.
In support of my colleagues in Hereford, yeah, geography is a big issue because they're a long way from anywhere else. The Monday night operating list guarantees an overnight stay, less than 23 hours, but it guarantees overnight. And I'm always slightly nervous of graphs where we're bang on 50%. That suggests to me that if this is from February 2022, which is the shortest month and the one with half term in, I wonder if we're actually recording 4 out of 8 or something like that. Do we have the absolute data, or are we just looking at the percentage there? You see what I mean?
So you this is data from your organisation. This is not data that Model Hospital is interpreted at all. So you can absolutely go to your informatics teams and ask for what data they're providing to Model Hospital and get that analysis and do that analysis if you feel it's useful. Certainly, there's an awful lot of data crunching that is going on. We've identified certain things within our organisation that come down to the slight idiosyncrasies of way we code. So it's important that we look into that, and perhaps we can talk about that in a minute as we go further forward, because coding is actually the key to ensuring that this data is proportional and is correct. So, Mehmed?
No, as a urologist also, and being on to the management for a while, I think Simon has a point, and we have noticed that in other GIRF meetings also. I think we need to look at our coding and booking system, and that is one of the main reasons that our day case numbers percentage is coming down. And I think we have corrected that, and another specialty has improved. It's on the booking. On a maxim, we need to click the right box for booking as a day case, and I think we will look into that in the future that it is corrected.
Great. Frank?
Yeah, just quickly, Simon's hit the nail right on the head as to why some units drag their day case numbers down, and you may be able to do something about it or not, but we know that's why these figures turn out like that. But if there should be somebody from coding here at this meeting, if there isn't, then you need to be highlighting to them what you think are numbers which don't seem right. There is a coding arm of GIRF who are looking at coding, for example, for tonsillectomy, which is all over the place. There's about 6 different codings for tonsillectomy alone. Please get your coding people involved, because they're the ones who are sending this information up the line.
Absolutely, absolutely. So, Kieran, can we just move on a couple of slides, please? So if we go on to the next one, because we'll go through these. Next one, please. So these are your tonsillectomy rates for your adults, and there's you are where you are with that, and we've discussed coding. The other thing that we've picked up, and you need to be aware, and we're going to talk about coding quite a bit, is that we all get a feel within our own organisations about where we are from a point of view of our plan and intention to treat. you've got to be absolutely sure that those patients, that the coding team is stripping out any cancer patients in this, because there should be no patients going through to the model health data set who are having, say, for example, a pan endoscopy and tonsillectomy. This is the cohort of patients who are having tonsillectomy for sleep apnea, or, well, when we get to children, sleep apnea, but in adults, tonsils, quinsies, the infective exacerbations. It's not to be treating patients who are having an oncological investigation or treatment as a day case who are having tonsils. So ensure that if you have any interest in just looking at your data, making sure they're stripping out that coding data regarding the cancer patients. Okay, if we can carry on, please, Kieran. So if we go to the next slide. I think both Simon and Steve articulated very well why their children's data might be slightly lower. The challenges with sleep apnea across both sites, and it's interesting that you're refreshing that data and trying to work with your anaesthetic teams, because there's quite an interesting article that's come out of ENT UK and the British Association of Paediatric ENT Surgeons a couple of years ago about relaxation of the criteria for managing and tertiary referral of patients with sleep apnea. Do you still do sleep studies routinely on patients, Steve, Simon, in your departments?
I don't. I make an assessment of the parents. If the parent is sensible and they say their child has obstructive sleep apnea, then they do. If the child stops breathing overnight and the parent is sensible and the parent has not noticed that, that's because they don't. If you get into, because it's such a horrific thing to watch, isn't it?
Yeah.
So if you get into the area where I'm nervous, or when we have, you know, kids with anatomical variations, actually I have a very low threshold of sending them all up the road to the children's hospital. The wait for a sleep study for paediatrics is about 9 months. They've grown out of it by then. Well, you know what I mean. So if they really need intervention, they go somewhere else.
Fine. Simon, what's Hereford's normal plan for these patients?
I don't think we have a overall policy. I think it's down to the individual consultant. I do order overnight oximetry. We have about 4 to 6 week wait for it, so it's very quick. Primarily, the decision to treat is based on the history, and parents nearly always bring a video, which I think is far better than overnight oximetry. But it's quite useful. The anaesthetist sometimes is a bit of reassurance, and also sometimes if you've got worried parents, but the history doesn't sound particularly convincing and the kid looks well, it's nice to say, you've had a sleep study, it's normal, don't worry. But we don't have any sort of, you know, metrics that we use. And as Steve says, if I got a funny, a kid with a funny syndrome or cerebral palsy or Down syndrome, I will do overnight oximetry, but I've got a pretty low threshold for sending them up the road.
Okay. And from a point of view of your intention to treat and those patients with apnea of appropriate age and weight, over 15 kilograms or 12 kilograms, as you're trying to move it down, is your intention to treat in those patients who are doing it with apnea as day case, or do you keep them in or keep them in overnight?
Personally, I've moved to trying to send them home. I'm fortunate in that nearly all of my sessions are with the same anaesthetist.
Yeah.
So him and I sing from the same hymn sheet, and it's pretty easy to have a policy between the two of us that these kids go home if they're within those criteria. So I use the criteria which developed up in Bradford, which is broadly, I think, the same: over 12 kilos, ASA 1 and 2, no other significant airway comorbidities, live within 30 minutes, etc.
Okay.
But I before I went off on sick leave, one of my to-dos was to try and get a policy adopted across the trust, which I think will be a lot easier now with the ENT UK position statement on that.
Great. Good. Steve, what about Worcester's attitude? Are patients routinely admitted overnight or plan to be discharged with apnea?
The children who are deemed to be high enough risk that they're going to get their operation done in Worcester stay overnight. It's an anaesthetic rule, and I can't shift it. But as Simon says, we've got this new recent data. We're going to talk to them about their audit meeting next month, and we'll see if we can shift it there. But currently, we expect to keep them, and we do.
Fine. Okay, great. Okay, Kieran, could we move on, please? So those rates for admission are fine. You're really quite low compared with a number of the other peers, and I would suggest actually for an acute trust you're in an incredibly good position, because I imagine whilst I don't know which the green ones are below you, perhaps they're non-admitting units. Or don't have any particular volume. Okay, if we can go to the next slide, please. Again, and I think this is a reflection of what you've both articulated, in that Wye Valley patients, because of the way the on-call is configured, would be likely to be moved up to Worcester. Would that be correct, do you think, Steve? Would that be your interpretation of that as well?
I hate to use Mr. Prowser's team as an excuse for my poor performance, but that's a data question, isn't it? If the baseline is 600,000 and the emergency population is 850,000, that would shift my data in the right direction. Although I genuinely don't know what we're counting here.
Yeah. Okay. Well, so what should be being counted is that the data of a patient having an operation, and this operation as a tonsillectomy in an NHS hospital being readmitted anywhere and readmitted to your hospital. Okay, if we move to the next slide, please. And I think we'll carry on. We've done this again, please. Okay. So this is an interesting thing, and this is a non-elective adult ENT admission with no procedure. And what this means is those patients who are admitted as an emergency and then have no procedure that results in a code. Now, procedures could be, for those for Steve and Simon, drainage of quinsy, packaging of nose, flexible nose endoscopy, removing foreign bodies, etc., etc., etc. Do you know in your hospitals, or how do you run the emergency take? Do the patients come to your clinic first during hours, processed and then admitted, or is there a generic surgical admissions unit in each of the hospitals you work in, where the patient comes and is assessed, nose is packed, quinsy's drained, airways managed, and then could be going home within 6 hours, or might be staying in? How's it configured in your individual organisations?
Shall I go first? A couple of different ways into the Worcester Royal. You can walk in the doors of the emergency department, in which case we have a very low threshold for almost skipping the emergency department altogether. It's not as it used to be, where they take a history and start treatment and stuff. We really ship them straight through where we can. So the airways and the significant people stay in resus and wait for us. Everyone else has a conversation with the SHO. We do have a surgical clinical decisions unit, which historically, politically, was really run as an extension of general surgery. So we found it very difficult to get ENT patients seen there, but that's got very much better in the last 3 or 6 months. So we've got some space there, and it's working better. So we can run the Portsmouth protocol for patients who have tonsillitis that mightn't be able to go home the same day, and that's working better than it was. We also have an emergency clinic which runs nearly every morning of the week, run in our outpatient facility next door to the consultant. So the junior doctors run that. So if your GP rings up and says, this guy's got an ear infection, needs to be seen today, then those ones which are not A&E kind of ones get dealt with in the clinic, and that sort of works quite well. Some patients are admitted from there, but the vast majority come in and have junior intervention and go out again. I mean, I think the difference for us in the last little while is access to the surgical clinical decisions unit, which works very much better than it did.
Okay. So on that note then, Steve, so if you end up in the surgical decisions unit, do you know if the patients are automatically admitted onto IPM, or they're seen and processed from an organisational point of view as a clinic visit?
Those are not patients who are admitted. We have not made a decision to admit those patients. It's an assessment area. And if we after 4 hours fail to turn them around, then they get pulled to the head and neck ward if there's a bed there. Okay, so if I can go, and do you know how the coding is being done on your patients, Steve? That you may not. I don't know, but what I'd like is for those patients to be seen as if effectively we've seen them in the emergency department and they went home treated. But I genuinely don't know. Could I don't mean to surprise anybody, but Mahmood, is there any? Are you able to? Do you have any ideas on how the organisation codes those inpatient or urgent stays, or sort of that sort of 4 to 6 hour type stay that Steve was talking about?
No, really, we would need to talk to them, but we have our SDEC unit where the people are seen for any surgical emergencies which are non-urgent but need immediate attention or any diagnostic test. And then if they need admission, they go from there. So as we know, we don't have any inpatient facility for ENT at the moment. So I'm not aware of that any ENT admitted here and need a coding for that.
Okay.
No, essentially from ENT point of view, they, as you mentioned, they will go to SDEC or A&E, and then our ENT SHO will see them. And if they're going to need an admission, very likely that they will be transferred to Worcester, unless in certain circumstances they need their airway secured, in which case we will do a surgical procedure and then transfer to the ITU team there. And we also similarly run an ENT emergency clinic on every day, run in parallel to the consultant clinics, or a middle grade clinic in parallel. So from a coding perspective, I think a lot of these do go under A&E. I'm not sure if they will get admitted under ENT, but I suspect most of them will stay under the A&E umbrella, because oftentimes when I see them for follow-up, I don't find much in the way of sort of notes to find, but it's under the A&E umbrella. Thanks.
Thank you. Sorry, Steve, do you want to come back in?
Only one comment, which is that the Hereford Emergency Department have the backup of a team of Hereford ENT surgeons who are on call, and there's a consultant on call all the time. And one of our little frustrations, which I know that Simon and Safe have heard before, but I'll say it again anyway, is that the Hereford Emergency Department picks up the phone and speaks to my SHO at lunchtime on a Wednesday and arranges admission effectively. And if my SHO isn't switched on or has only just started last week, they say, yes, that sounds fine. And then the patient gets shipped to a different county. They see our most junior doctor in the emergency department who says, I think you're okay, and sends them home again, except you have to pay for a taxi to go home. You can't come in an ambulance. And that's one of those little wrinkles related to our service, which we are somewhat embarrassed about.
Okay, thank you. Just as an aside, you may be, and this is something that I've discovered within the organisation I work in, and I don't know whether this was a national mandate during the COVID pandemic, is that coding in of inpatient stays is often now done electronically from theatre notes. And if that patient didn't have an operation, then it's done, the coding is done from the discharge, the electronic discharge summary. Now, why that's important, as we've discovered within our own organisation, and you may already have very fantastic plans in how you manage your coding, but we've discovered that our numbers of patients who were admitted with no procedure was very far out with where we actually were. It was just that we were missing those because we weren't putting flexible nasendoscopy, drainage of a quinsy, removal of the foreign body on a discharge somewhere, and as a result, coding weren't picking these up. So it's just something perhaps to discuss with your coders as to how they do that within your own organizations, to see whether you're in a position to change the dial on any of this just by some very, very simple actions. Because as Frank has previously suggested, and I get a little bit boring about talking about it, is coding is key, because this is all about coding. GIRFT is all about coding data, and if you can get your coding data correct, then it gives you a much better sense of what is going on in your actual departments. Okay, so if we can move on to the next slides. Next one, please. So I'd be really, these are the virtual attendance rates for adult outpatients within your systems. I suppose it would be really interesting to understand from Safe, Simon and Steve what their view regarding what the utility for virtual is within your individual departments, if there's any benefits, barriers, problems that you have foreseen, whether you think it's useful, terrible, waste of time.
Yeah, essentially, it's very much person dependent. I mean, it's about probably, again, as you say, coding. I mean, I ring patients with the results quite frequently without necessarily putting it down as a virtual clinic. Perhaps if I had booked them into a virtual clinic where I telephone them to tell them the results, maybe that would push the bar up a bit more. But as a utility, mainly for follow-up, I see it as being useful. Yeah.
So Safe, so can I just confirm? So you're speaking to patients on the phone, giving them results, and obviously presumably telling them what your next intention is. Would that be correct?
Correct. Yes.
I think your hospital will be desperate to have that coded, because that's an outpatient virtual attendance. So they would like the revenue associated with that. And actually, I'm sure they could set up some very quick codes for your admin team just to book these patients in, even if you're doing them on a sort of an ad hoc basis. That's something that could be done. Simon.
I mean, I'm going to pretty much echo what Safe says there. Yeah, every week, dozen or so patients I'm phoning up to let them know their scan results normal, or next plans, etc., to discuss things. And at the moment, that's just happening. Whenever I'm doing the admin, it could be on an evening, so it's not getting coded. So I think we need to look at ways to code that. In terms of formal remote clinics, I'm not going to make comments. I'm going to hand over to Steve Lewis, because we're pretty much on the same page when it comes to remote clinics and ENT. So I'll let Steve loose now.
Sorry, I've just walked behind my computer to plug the thing in the wall. I've missed the last little piece of that. We're talking about what percentage of ENT contacts reasonably could be dealt with without the patient in front of us. I think there are small groups who we could deal with on the telephone. I think my head and neck cancer colleagues who know patients very well might get away with some follow-ups on the telephone where they know the patient's sensible, They're asking about symptoms as a checkup and perhaps not an examination on every occasion. My personal feeling is that for the ENT is a diagnostic specialty, isn't it? The GPs, the GPs don't say this chap's got, you know, a hole through his eardrum, can you repair it? What they say is this guy can't hear, why? And that does require kit. I don't actually ring very many patients to give them their results. I write them letters because I think it's important to have it documented, and the patients really like to have it documented so they can reread it. So I've always copied all of my communications to patients. So if I were going to ring a patient and give him his results, he'd need a letter as well. And my secretary's going to have to type one thing. She may as well type the letter that says, just to let you know your results are okay. And then it's all done. I have difficulty with the idea that we might, I think the target is sort of 25% remote, isn't it? I mean, I think the people who need results don't need to come at all. And I think there's only a small group of patients I could identify where I'd be comfortable not looking in their ears or looking up their nose. What do you think, Matt? What do you do?
So I think I share some of your concerns regarding virtual, but I think there are cohorts of patients that we can undertake virtual clinics appointments for. I think managing those vertigo patients, for example, when you don't need to be seeing them necessarily, but it's just medication changes. I think there is a certain amount of stuff that you can do in a thyroid clinic that for example, that could be managed. I think there's the patients with long-term hearing losses who see a pediatric audiologist and then end up seeing the ENT surgeon on a different day, and repeating everything that has previously gone on is an unnecessarily use of time. So I think it can be done. I think there has some utility in virtual clinics in ENT, but not at the same level as, say, for example, an endocrine clinic or a rheumatology clinic, but perhaps more endocrine than rheumatology, where, say, for example, you're managing blood results rather than physically having to examine a patient. So I think there is a role for virtual clinics in ENT. I think we had it, frankly, chucked in straight at us on March the 26th, 2020, with little previous thought for it. And this is an evolving practice that some people have used and continue to use in considerable numbers, and there are others that aren't using it in considerable numbers. And I think somewhere in between is probably the right point of the scale, because we can't assume that those people on the right-hand side of this graph are using those virtual appointments effectively. So historically, during what we've seen during many of our GIRF reviews is that the people with the very high virtual appointments have those that have really struggled to restore. And as a result of struggling to restore face-to-face, they've been using a virtual appointment almost like a holding pattern before they can land the patient for the examination and management that they actually need. So when I was at pains to say this is not about performance managing, this is about just seeing what your views were within your organizations, and particularly because you've both said that geographically there is quite some distances the patients have to travel, whether there is opportunities to be using remote type access facilities to allow patients to have more virtual offering. And on that note, I was wondering whether we could just talk briefly about what is your CNS, clinical nurse specialists, AHP roles, specialist nurses. Do you have those within your departments, and how do they get utilised? Simon.
Yep. I was just going to add, actually, on that telephone thing, if that was a performance metric we were being measured against, I could easily get 90% telephone rate just by gets triaging every single patient for a telephone call on first triage, even if they've got a foreign body stuck in their nose, and then mark them off as having a first appointment by telephone. It's not a marker of whether that's useful or not. I digress. So we have two advanced nurse practitioners in Hereford. They support our head and neck cancer patients, and they provide an oral care, so microsuction service between them.
Thanks, Simon. Steve?
Go on, Frank, you've got your hand up. Let's let you back in before I get to my bit.
Thank you very much. I don't want to take too much of your time. I'm just an observer. The virtual attendance rate almost certainly was a construct to see if you were transitioning from COVID practice back to normal practice. So it's not meant to be either critical one way or another. It was meant to see which departments had gone back to pre-COVID practice. Personally, I actually audited. We, of course, like most departments, we all went over to everything being virtual on the telephone with patients, except for as a triage before seeing them as a new patient. I've found that since most of my patients are either 2-week or urgent referrals, that the virtual first attendance became a waste of time, and I don't do first attendances by virtual now. But follow-up, it's fantastic, especially for the regular cancer patients, but also for post-ops. And the question is whether consultants should be following up patients post-op or whether it should be a nurse specialist. Obviously, the juniors do it as well. So I think virtual is, from a patient's point of view, we audited that as well, and the patients love it if they don't have to come up and sit in the outpatients for 2 hours and have to pay 10 quid to park their car. So I think it has its merits and it has its demerits. I don't think it's how you want to work your service, but my view is that the patient follow-up can be very effective and very efficient virtually. From a head and neck surgeon's point of view, it's not that much use as a triage. I think as a triage for other conditions, it might be worthwhile if you think you could deflect patients, but that would be something that I think you'd have to think about as an individual.
Steve?
Nursing support. We have a specialist nurse who runs a microsuction service and actually we've picked up that entire service and put it in a practice in the community, so we've got more space in the hospital and so the patients can park without messing around in our car parks. We've recently appointed a second nurse to support her in that role. We've got a clinical nurse specialist who deals with the 2-week wait triage primarily, but has other roles as well. And we've got a couple of sort of cancer specialist Macmillan style head and neck cancer nurses in terms of specialist nursing support. In terms of, in the answer to your nursing question.
Yeah, great, thank you. And do you have any of your other teams, your allied health professionals, for example, your audiologists doing standalone type clinics in support of ENT, for example, grommet review clinics, tinnitus management clinics, vertigo review clinics? Is that something either the department thinks is useful or is intending to progress? Steve?
Well, I'm going to hand you over to my chief audiologist, Mel, to tell her how much she does it. Tell us how much she does in her department. But yes to all of the above, in short. Mel, tell us what you do.
Yes, we do quite a lot virtually. We do a lot of tinnitus work virtually. We do some virtual follow-up with hearing aid users. We do some work, like Steve mentioned earlier, the audio before ENT. We do and have done for many years post-op grommet reviews. We do some work with balance that could probably be expanded. So yeah, we do quite a lot standalone clinics really.
So Mel, if I can come back to you, the clinic that stands out as the one that I've not heard of before is the audio before ENT. It would be I don't know whether you'd be happy to share offline about how that's structured. You don't obviously have to say yes or no in this environment, but if it would be possible to have a chat with you about that would, I'd really value that, because that's something I think an awful lot of departments could use and utilize, and I'd be interested to have that conversation, particularly when Steve's not in the room, to find out what problems he's caused you.
Absolutely, I'm more than happy to do that. I mean,
Fantastic.
It's actually worked really well, and we did take baby steps to start with, but it has grown and it is a very valuable resource. I'm more than happy to share.
Well, I think that'd be great. I think one of the problems that we have within the NHS is that we are always trying to reinvent the wheel, where the wheel has been not only invented, built, and is running like a Formula One car elsewhere, and we just need to try and get that information and disseminate that information. So yes, that would be really fantastic if I could pick your brains about that, if possible.
It costs you a pub lunch, though.
Sorry?
It'll cost you a pub lunch. These things aren't free.
Yeah, but Steve, you won't be invited, so. So, good. Great, that's really very, very helpful. And Simon, from your point of view, is there anything that you do down in Hereford? Any different?
Probably not drastically different. About 5 years ago, we changed our paediatric hearing loss pathway. So now all referrals for kids with hearing loss go to audiology. We've got a separate paediatric audiology department. So that could be a health visitor, school failed screen, or GP, and they see the child and they do the hearing tests. And if they've got glue, they follow them up and they do the 3 or 4 month follow up. And then they refer to ENT only if that's a persistent glue ear. So we're not seeing these kids. So, you know, I do a paediatric ENT clinic, and I only see kids who've already been screened out by the audiologists. If they detect other pathology at the time, then they will push it through to me before their follow-up. And then once the kids had their grommets, they get discharged. They don't see me or any other ENT surgeon again. They go straight back to audiology. Unless there's a pathology.
That's great. That's very good. Thank you. Okay. Has anybody else got anything else they'd like to mention about this aspect of clinics before we just move on? Okay, Kieran, do you want to just move on to the next few slides? These, if you move to the next one and the next one, because we've done virtual. Okay, carry on, please. So these are your outpatient follow-up ratios for adults. I imagine that you're looking at this and you know where you are from a point of view of outpatient follow-ups. Do you know what your backlog, partial booking backlog is for your follow-ups within individual departments? Do the operational teams know that? And how do you manage that partial booking out backlog?
So do you mean outpatient waiting lists to see us?
Patients. How do the operational teams manage that on your behalf? Do you know? Or are there any of the operational managers who can comment on that?
Julie, are you able to comment on that one for me?
Yeah, okay. So at the moment, we've just got about 3,500 patients on our outpatient waiting list. We've got, I'm just adding the just under 900 patients that are sitting on our partial booking for follow-up. So obviously we're not P-coding our outpatients, but our outpatient referrals at the moment. So what we do is we obviously focus on waiting times to flag to our consultants. Not sure there's anything else anybody else would like to add to that, Steve or Becca. No.
Is there a system within the two organisations highlights to either the operational teams or the clinical teams of patients waiting longer than expected for their follow-up appointments?
Yeah, sorry, Vanessa, in Worcestershire, what we do is we have an outpatient, like a 642 process, where we look at all patients that are on our waiting list. We look at all the clinics and make sure we're maximising on those. And we have internal targets that we set ourselves. So from an outpatient point of view, our current target is no patient waits for a first new patient over 52 weeks. At the moment, I think we've got 30 patients over 52 weeks, and then we move the targets down to the shorter time to decrease the length of time people are waiting. Okay. Could I ask? Oh, sorry, I've got a couple of hands up here. I can't quite see. Where's my Vanessa?
Yeah, so in Hereford, we have a risk stratification where we're looking at follow-ups on at least a weekly basis. We know which patients have passed their requested follow-up date, and we follow those up, discussing with consultants where necessary, any urgency or anything that needs to be escalated where we can't get them in. So we've got our eye on it all of the time.
Great, good. Steve?
I think this is an area that makes me nervous. I think we understand that we've got a lot of patients we haven't met yet to make a diagnosis, and we understand we have to risk stratify those people. But I am nervous of the people we've seen once who have a bit of awkwardness on swallowing, and we're going to see them again. And I think there's a possibility they sometimes might drop through the net. I'm going to a meeting next Thursday about how we run outpatients, because actually the whole booking system is something that I don't really have my finger on the pulse of. And I think probably, if I'm being honest, we could probably do that better and more securely, although I'd be very happy to hear how anyone else does it, as if there's learning to be had. Okay.
So just going back to something that we talked about really early on when we were talking about the waits for clinic. As of the end of April, there were 827 patients at Worcestershire in the ENT department who were waiting for longer than 52 weeks. But in Wye Valley, there were 12 patients who were over 52 weeks. Is there any cross-fertilisation stroke mutual aid available between the organisations? Is there any, has there been any discussions of sharing patients across the organisations to bring the weights down on average across both organisations? Is that something that's discussed, or is that not on the agenda? If anybody's got any comments.
I think that's something we need to be looking at, isn't it, Vanessa? But we haven't done anything to date from an ENT perspective. We have for orthodontics, but not ENT. But it's certainly something we need to look at, I believe. Okay, and Julie, I think I'm right in saying that you're at Worcester, aren't you? Yeah, and that's correct. Yes, I'm nodding, which is not helpful. Yeah. And Vanessa confirmed that Choose and Book wasn't open down at Hereford, but do you know if it's open up at Worcester? Choose and Book for Choose and Book is open at Worcester. Okay, and the time horizon for that at the present time is what? I don't know the answer to that question. I'm not sure. That's something I have to come back to you about. Okay, and is that Choose and Book only open once you've built the clinics, or is it open for anybody to book into, and then you will organise the clinic times? I think, I mean, I'm going to look to Becky because she deals with a lot closer than me. Becky, you still on the call?
Yeah, I'm here.
So in terms of our Choose and Book, the clinics are open 6 weeks in advance as a minimum, aren't they? And are they just allowed to, anybody, as our GP colleague can book into them as they are currently?
Yes, they can book into them, because obviously there'll only be the slots available for the patients and GPs to view that are open there, sort of thing. So they're ready to book into.
So does that mean then, Becky, that if you haven't opened up the clinics 6 weeks in advance, then your patients aren't able to book into any slots?
Correct.
So what happens in that situation?
Well, we can't really, we don't let ourselves get into that situation. So we're always booking further ahead. And then obviously we have to put the cancellations in if we get, you know, clinicians cancelling for annual leave, because obviously we've got our 6-week rule for the annual leave. So those would go in and then patients would have to be moved. But other than that, the slots are there for a long-term period for patients to book into.
Oh, so Becky, if I got this wrong then, so I could be going on, if I was down in Worcestershire, if I was referred by my GP into Worcester, then I might see her time horizon of 26 weeks or 50 weeks or whatever it is at the time, and I would be giving a date and a time for that.
Yeah.
Okay, so you don't only have clinics open for choose and book open for 6 weeks. It's open for as long as it's required.
Yeah.
Okay, that's fine. Okay, that's very helpful to understand. Okay, could we go on, please, then, Kieran? Carry on again. And again, please. And again, because I think this is all roughly on the same thing that we were talking about those discharge rates, etc., etc. Carry on, please. And now this is a really interesting slide, only from a point of view of interpretation. So initially, when you look at this, the background to this is understanding how many of our patients are being discharged after a first ENT attendance, and you'd think that the higher your number is, the better you are. But actually, what's interesting is that this is thought to be a surrogate of the quality of the referrals coming into your department. So in fact, the top decile is below 12%. Because that suggests that you've got a very, very good referral management system. And certainly from hearing from both Simon, Saif and Steve, the fact that every referral coming into your organisation from an ENT point of view is seen by an ENT consultant is very laudable and incredible. I think very, very few departments are mirroring that. And I think it would be fair to say I top my hat off to you both, all the three of you, for doing that. And that's probably why you're right down at the bottom here, because you're rejecting those that don't need to be seen. You're helping with advice and guidance for those that may need some help but could do some bits and bobs first. And as a result of that, you're only seeing the patients you need to see. So that's very commendable. Next slide, please. Carry on, please, and carry on. So theatre metrics. Now, I don't think there's a huge amount to say about this, because these are 3-week snapshots. So I'm going to be speaking. We've introduced and we've discussed at our national meetings about actually lengthening the snapshot we take here, so it gives you a bit more information. But if we can go on to the next slide, please. Oh, I think that's 2. I think that was 2. Oh no, sorry, Kieran, if you do move forward, it's slide by slide, that'd be great. So theatre utilisation is pretty good, and the small little squiggly line chart tells you whether you're improving or reducing. And I think you're pretty static across the system at the present time. Next slide, please. Your touch time is not bad. Clearly, there's some room for improvement there. If you go to the next slide, please. Kieran. Okay. Next slide, please. Oh, it's only why. Can we go to the one? Sorry, can we go to the previous slide, please? So your late starts at the system level are, as you can see, very impressive. I I will. This is the bit from a surgical point of view that I'm really interested in. Are your wards co-located by theatres?
So at the Worcester Royal, we have a theatre admissions unit, and the rule is, irrespective of whether you think there's a bed or not, the first patient on every list gets sent for at risk, and you just get on with the work of the day. In Kidderminster, there isn't an A&E department, so there's no competition for beds. So Kidderminster runs like clockwork. And if we follow the rules in the theatre admissions unit, then that works like clockwork as well. Actually, it's not quite that easy because genuinely the hospital is sometimes very full, and we don't start on time. There is also a little bit of counting error, which was brought to my attention recently. I think actually we over-report late starts, so this might even be better than that.
Well, that's very impressive. Co-location of wards really helps the send. The presumption of ascend, I think, is very important. Other organisations use holding bays as well, but clearly you don't need much help in getting your list going because they seem to work very well. Okay, next slide, please. Next slide, please. Intercase, can we go to the next slide, please, Kieran? Because this might show between the... I've never seen figures like this on a GIRF review. I don't know how you manage it. I think we've got a lot to learn from Hereford and Worcester. Simon?
I would probably pass to Safe to comment on these figures. My experience when I was operating in March was I can't believe those figures. I mean, our day surgery unit, which is co-located, was subsumed into the COVID response, and our interim day surgery unit was at the far end of the hospital. Now we're a small hospital, but it was still a long way away, and I was having real problems getting patients down promptly. So I'll hand over to Safe. I don't know if something's changed dramatically.
Yes, so now we do have a holding bay, I believe. So as you say, we had a day case unit, which is literally next to theatre, but then that was moved on to a ward other side of the hospital. But despite that, I think they were working on sort of reducing the times, and therefore they've set up a holding bay, as my understanding.
So Safe, you've got a holding bay at the moment, have you?
I believe so. Mahmoud,
okay.
Is that right? He's got.
Can I just, yeah, we actually have a surgical admission unit just beside the theatre with 7 or 8 individual rooms. So all the first patients are catered there for a right timely start, and then the patients come as we do go along during the day. And then the day case post-operatively is very co-located beside the surgical admission unit. So after the recovery, they go there. So turnaround time for the day cases is quite good. Although for some cases, we now having our surgical admission ward is on the first floor. But I think we are working on our theatre productivity unit with a stream of how can we decrease that time further by building a holding bay outside the theatre where the patient from the ward can come early and can, as soon as the patient finished, can go into theatre. So there's a lot of work going on, but I do agree that we have very good location of the day case unit beside the theatre.
Thanks, Mahmood. So it's really interesting because many hospitals prior to COVID had a holding bay, and there'd be 6 or 7 patients in there, depending on the size of the surgical unit that you were providing patients for. Certainly in our organisation, COVID came along, restoration came along, and the holding bay didn't come back along. And as a result of that, the lack of co-location has resulted in huge intercase downtime delays because patients are coming a long way, and that was because there was blended pathways with green pathways, amber pathways, and we didn't want patients ever to be mixing. So you've done a sterling job looking at that. Mehmood, back to you.
Yeah, just to edit, because it's going to improve further, because we in ICS has been allocated, are going to build a standalone day case unit outside the hospital with its own admission and discharge facility, and all those specialties who are doing the day case maximum, like ENT is one of the top of them. So this time will further decrease and efficiency will improve further. We're hoping to start in January 24 in utilization, hopefully.
So it would be great to come back and be invited to come back and do a review at some point in the future where you're even better than you are now, because those figures are quite remarkable, actually. Can we go on to the next slide, please? I suppose there's always the best bits, and then there's a little bit of early finishing. So is there a reason, is there any comments from the clinical teams as to why that might be the case? Can we go to the next slide, Kieran, while we've got that up? Steve, please.
Yeah, early finishings. I think there are two comments. We're pretty picky about booking operating lists to 100% of the predicted time it'll take. So we've got a system in place whereby I know that including anaesthetic time from sending to putting a patient back in recovery, my time to do a tonsillectomy is 43 minutes. And we book according to that data, and there really isn't any flex. We do that quite effectively. If you then give me the fastest anaesthetist in the world, we finish early. The other irritation is that because of the restrictions of COVID, we don't have a kind of a standby patient. And if 3 days before the patient tests COVID positive or drops out for any reason, you can't get another one in to replace them. And so this is worse than it used to be pre-COVID for that reason.
I share every single one of those comments, Steve. The effects on COVID, on positive COVID rates, those 3 days before, plays absolute havoc. And our figures and figures that we're seeing all over the region have deteriorated post-COVID. And it's interesting that you brought up about the challenges in not having the same anaesthetist all the time, because that has a massive impact on the productivity of one's lifts. Do you use surgeon-specific timings, or do you use median procedure timings?
Surgeon-specific timings. So 43 is my time, not anyone else's, but that is an average of all the tonsils I do and all of the anaesthetists I work with. We are trialling an EasyJet style system whereby one patient is added extra, and that patient knows that they're added extra, and they know that they might get called, but they're the last person, so they might not. And so there's room for improvement in terms of filling that last gap, but we haven't really got a brilliant solution for that yet. Just hoping that it goes away.
How's that going? I mean, I would hesitate to call it an EasyJet solution at the moment in the current climate, but maybe think of something else. But how's it actually going? Does that work? Is that working out for you?
It is in its infancy. Julie, right. Do you want to comment on that, or Becky?
Yeah, I was saying it's very much in its infancy, but so far the list that we've added that extra patient to on the Kidderminster site only, it is working really well. We're going to pilot something differently, as in we're going to add it to more lists in the first week in July. We're doing as an organisation a perfect fortnight, so we're going to be identifying that extra patient for more lists than we are currently. But so far so good.
And can I just, have you had to actually cancel any of those patients?
At the moment, no.
Stand them down. I don't mean cancel them, stand them down.
Not at the moment, but as Mr. Lewis said, it's very much in its infancy. I hope I can say exactly the same, answering exactly the same way after the 2 weeks where we start adding more standby patients to more lists.
So it would be really interesting to share as well how you're getting on with that. If we could mine you for that information in sort of 6 to 8 weeks time, because if that is something that works, that would be something that I think would be a very interesting development as a proof of concept, which you appear to be going through at the moment. So we might be knocking on your doors on that one as well, if that's okay. Say.
Yeah, I don't think we can quite mirror that in Hereford because, as you say, the ministerial work that has come through with the pre-COVID, so the COVID screening and getting them to the operative list, and then any changes to the management would take a lot of secretarial support. And at the moment, we are slightly, I would say, fairly light on secretarial support, but we are working on that. But that may reflect potentially being underfilled in certain theatre lists. I think that there's some of that as well.
Great. Thanks for that explanation. So we're sort of towards the end of our allotted time now. So I was wondering if anybody's got any other comments that they would like to make, any burning points they want to add. If not, I'll wrap it up. Has anybody got anything they'd like to ask or comment about? No. Okay. Well, I want to take the opportunity of thanking you all for. Oh, is that safe? Is that a legacy hand?
Well, I actually wanted to mention, because on the email you sent also some flowcharts on the management of laryngoplasty, tympanoplasty, and how it's done overseas. Was that going to be discussed, or what was not necessarily?
That's the 4 HVLC, high volume, low complexity procedures from the, which is a sort of like a partner project alongside GERFT, and they've been set up from and are currently being implemented in London to reduce variation across those 4 procedures. And they've been put in there just to sort of pique people's interest, to see whether they are in a position locally to introduce any of those that they weren't going to formally be discussed in today's meeting.
Yeah, I thought that was interesting, just including local anesthetic nasal surgery there. And actually, that's something I'm exploring locally. But there are certainly some very interesting thoughts, knowing if other people are doing it, then why not? You know, so that's quite interesting.
So local anesthetic fez, do you mean?
At least anterior fez, yes, for patients who are unwell and perhaps have chronic maxillary sinusitis and elderly, but you can potentially offer it, and it's certainly not it's not uncommon internationally, but I think in the UK it's not necessarily being thought of, you know, in the routine, but it's something we can offer an increasingly aging population.
Absolutely. It's interesting you say that, because that's certainly where I would come from it. I do a fair amount of local anaesthetic sinus work like that because of the cohort of patients that you've just described. But those four patient sheets or procedures, sorry, and flowcharts are just sort of to pique people's interest, really, and seeing whether there's anything that they could bring to their locality and their systems, to see whether that they can improve that equality of access and equity of access and speed through the system. Nicola.
Thank you. Just wanted to ask people, if you've not put your role and your site in the chat, please do that, because I'm aware that some people might have joined us late. I just want to make sure that I do justice when I added the attendees, and it's a great turnout today, so thank you.
Yeah. So just really finally, I just really wanted to thank everybody for coming today. I think Hereford and Worcestershire ENT review shows that you are doing things in a very joined up, efficient way by and large. I'd love to be able to say we're going to make hundreds of different suggestions and perhaps ideas about how you might want to take things forward, but I think that would be slightly disingenuous, because I think you've frankly thought of all of those great things that you're already doing, and you've demonstrated both emergency, elective, outpatients, management referral systems is all very, very impressive. So if nobody has got anything else to say I was proposing to close the meeting down, and we will be providing a report based on what we've discussed. And then we're more than happy to then have a further discussion based on that report if that would be helpful for yourselves, and we'd be more than happy to do that at any point. Okay. Thank you very much indeed. Thanks very much, everybody. Cheerio.